Hi learners, it's Em from Sound Nerds, and in this video we are going to discuss the thyroid ultrasound for the sonographer. So as a sonographer, it's probably relatively obvious why we need to learn the ultrasound appearance of thyroid tissue, but a big part of it is also knowing, what the indications are for a thyroid ultrasound. So when we're doing our patient history interviews, we can start to kind of come up with some differentials in our mind, what we might come across during the exam. It's also important that we know what equipment we need, so we are creating and taking diagnostic images. And a big one is that we know the normal appearance of the thyroid tissue. To recognize abnormal, you have to have a really strong mastery of what normal is. So we'll take a look at that, and we'll talk a little bit too about documenting the whole thyroid. It's really important to whoever's reading your ultrasound that they're confident you looked from top to bottom, right to left, the whole organ, and represented it in your imaging. The American Institute of Ultrasound in Medicine, or the AIUM, is a fantastic resource for sonographers. And on their website, they list several reasons for why an ultrasound of the thyroid may be ordered by a practitioner. The most common reason that we probably see an ultrasound being ordered is to evaluate the location and characteristics of neck masses in and surrounding the thyroid. Other reasons that we see ultrasounds of the thyroid being ordered is to follow up abnormal lab work, or we can detect recurrent carcinoma after a patient's had thyroidectomy. We can also use ultrasounds to follow up previous ultrasounds or other imaging modalities. And then lastly, oftentimes we use ultrasound to perform an ultrasound-guided biopsy. Since ultrasound is basically the gold standard for evaluating thyroid tissue, it is very, very common for us to get orders to look at thyroid nodules incidentally seen on other imaging. So always review previous imaging for any thyroid exam you have on your schedule. Another big thing that we use ultrasound for is to follow up other ultrasounds. Thyroids tend to be imaged, every 6 months, every year, especially if we have nodules that are kind of in the gray area for their suspiciousness. I always print off the previous worksheets to kind of use them as a roadmap in complex thyroid cases. Before getting your patient, you also want to thoroughly review their patient history, any surgeries or medication that they are on. Most of this information will be found in the patient's electronic medical record, but if you don't have access to this, you want to make sure that you conduct a full patient interview for pertinent information. A lot of times I will ask the patient if they can show me where the lump is or where they're feeling that globulous sensation. I'll ask them if they've had any problems with swallowing or any pain. I'll ask how long lumps have been there for, if they're on any thyroid medication, and really get a feeling for what symptoms brought them into the doctor originally. The patient does not need to come to the appointment with any special preparation. However, to prepare the patient for the ultrasound, you will want to position your patient in a supine position with moderate hyperextension of the neck. To do this, oftentimes I will either move the pillow under the patient's shoulder, allowing their head to kind of fall back onto the bed, or I'll remove the pillow completely. If that position is not well tolerated by the patient, I will take a towel, roll it up, and then place it under their neck, kind of at the base of their head, to offer a little bit more support. The thyroid is an incredibly superficial structure. Therefore, we need to use a high-frequency linear transducer to image the thyroid. On average, the frequency should range probably between about 7.5 to 15 megahertz. And it's also a good idea to have a curvilinear transducer handy just in case you have a very large thyroid to measure or you need to image through a very large neck. Unfortunately, the curvilinear transducer typically does not provide us with enough resolution to really assess the parenchyma well, but does offer a larger footprint for measuring large thyroids or very large nodules. Images of the thyroid should follow a protocol. The thyroid is relatively small and the protocol is pretty straightforward. The exam time itself is usually pretty short, lasting less than 15 minutes, especially if there aren't many pathologies present. Images of the thyroid should include both lobes in transverse and sagittal or longitudinal planes. We want to make sure that we're taking measurements at the mid portion in both transverse and sagittal. And then we want to use color to assess normal flow versus hypervascularity of the organ. We'll also include images of the isthmus with an AP measurement. And then lastly, we will do a comparison image of both lobes of the thyroid in transverse to capture not only the echogenicity of both sides, but the vasculature of both sides. A complete study may also include representative pictures of the lateral neck looking for abnormal lymph nodes. The next few slides are a representation of a full thyroid protocol, along with where the transducer is placed on the organ itself. So we are going to start with a transverse right thyroid superior image. In this image, we can see just the beginning of the thyroid tissue next to the trachea. Notice that there's no isthmus connecting at this point in our ultrasound image, and we can also see that's true on the diagram. Moving inferiorly in the transverse plane then, we are going to stop at the mid portion. The mid picture is taken at the widest portion of the right lobe. Oftentimes you will see it is connected fully to the isthmus. Calipers are placed to take a transverse measurement on the thyroid, and at this point some people do also take an AP measurement. If you take your AP measurements while in the transverse plane, make sure that your probe position is perpendicular to the neck to get a true AP measurement. Moving the transducer further inferior, we are going to get to the inferior portion of the right thyroid. At this point, you will still probably be connected to isthmus, but you will see less bulk to the isthmus. Some other structures that we can see down at this level, which we will again cover in a little bit more detail towards the end here, we can see the carotid artery, the jugular vein, the sternocleidomastoid muscle, the strap muscles anterior to the thyroid here, and the trachea medially. Now we are going to switch into the longitudinal plane, and we are going to work from the outside to the inside. So we are starting at a long right thyroid lateral position, which we are just getting the very edge of the thyroid in this image. If the thyroid hangs over the carotid artery at all, you'll most likely see that also in your longitudinal lateral image. Angling slightly towards the center, we are going to elongate the thyroid. The inferior portion tends to have more of a pointed end, where the superior tends to flatten out. We'll also see more depth to the thyroid tissue as we get to the mid portion. We'll do measurements in the longitudinal and AP planes if you did not do it in your transverse. Typically, we also put color on at this point to evaluate the vascularity of the bulk of the organ. Continuing to angling slightly to the inside of the neck, we are going to see that flat portion of the thyroid angle down, and then we will see that we lose the pointiness and the length of the thyroid on the inferior side. So we almost get an inverted triangle or pyramid shape as we move into the longitudinal right thyroid medial image. At this point, I will take a sweep through the lateral neck looking for any abnormalities around the thyroid, and if there are any pathologies present, I will complete my right-sided pathologies at this time as well. However, in the normal thyroid, then I am ready to switch to the left side. So we are doing a trans-left thyroid superior image. Moving inferior, again, we are going to look for the widest portion of the thyroid, measuring in transverse, and also in AP if that is your protocol. And then one last image at the inferior portion of the thyroid. If I have a particularly inhomogeneous thyroid, I might take more images than just one at superior, one at mid, and one at inferior. I might do a couple at superior, a couple at mid, a couple at inferior, showing how the parenchyma changes through the tissue. The other thing to keep in mind too is that you absolutely do need to label your sides. Notice when we have trans left thyroid, we can tell that this is the left lobe because we have isthmus connecting to the right lobe when we are using standard transducer positioning. When we turn into the sagittal plane, however, it is impossible to tell what side you are on, so be very diligent in labeling right versus left. This is an excellent image to be very comfortable with as you are learning the relational anatomy of the structures around the thyroid. Again, we have the inferior portion of the left thyroid. We have the carotid artery, the jugular vein, the omohyoid muscle, the sternothyroid muscle, and the sternohyoid muscle, which are the three strap muscles. We can see the sternocleidomastoid muscle over here, the longus colli muscle below, and we can actually see the esophagus very well on the left side. Now, most anatomical graphics will put the esophagus very central, right behind the trachea, but is typically best seen when we're coming from the left side. Typically don't see it as well on the right. Again, we'll switch into the longitudinal plane to work from the outside in. So we have our lateral left thyroid image, angling slightly towards the middle. We're going to elongate the thyroid, again getting kind of a pointy inferior tip and a flattened superior tip. Make sure to take a measurement and get color images at this point. Angle a little bit more towards the center and we will see the medial portion, again losing the superior border, losing that inferior border, and getting kind of an upside down triangle. As you move towards the trachea, you will actually see these little white echogenic rings. Those are the cartilage rings of the trachea that keep it open. Again, at this point, I would do a sweep through the lateral neck, checking for any abnormalities out there, and then also complete any documentation of pathology seen on the left lobe. Next, then, I go to the isthmus, so I will be very central on the neck, very centered on the isthmus, finding the widest portion, zooming into it, and taking an AP measurement. As a review, the isthmus is the tissue that connects the right lobe to the left lobe. It literally means bridge, and we want to make sure that we are not measuring into the trachea. There should be a clear fascial plane around the thyroid tissue, and that is the area that you want to include. We start to see some reverberation artifact through the trachea due to the air that is within it, and so sometimes that can make it difficult for that posterior measurement. Lastly, then, we're going to take a bilateral image of the thyroid. You have a couple ways to do this. If the thyroid is small enough and your transducer footprint is wide enough, by using the convex imaging that you can see here, we're kind of extending our field of view and are able to nicely get the thyroid tissue on there. This image allows us to compare both sides and to really evaluate the thyroid as one. We also are going to take a color picture, again, to compare the sides of vascularity. You can sometimes have focal areas of hypervascularity, or you can have the entire thyroid really light up with color, which typically indicates hyperthyroidism, which is often seen with Graves' disease. The other option for a bilateral transthyroid image is to dual screen it. So you would take an image of just the right lobe, and then you would dual screen, shift your transducer towards the left side, and then take an image of the left lobe, trying to kind of match up so you make sure that you're at the same level of the thyroid. As a side note, if we do have a patient who has a rather long thyroid and the superior and inferior borders are not visible using the linear transducer with the convex view on, then at this point I would switch to a curvilinear transducer just to get my measurements. We need the high frequency of the linear transducer to really evaluate the parenchyma of the tissue, but the curvilinear can offer us a bigger footprint for more accurate measurements. So speaking of measuring, we do use ultrasound to make measurements of the thyroid, which can help us to identify normal-sized thyroids versus those that are rather big. The normal length of an adult thyroid is 4 to 6 centimeters. So just kind of as a rule of thumb, if I have to pull out the curvilinear transducer, then it is most likely a little bit longer than what we would expect. The width typically ranges from 1.5 to 2 centimeters, and the height, or the AP measurement, is 1.3 to 1.8 centimeters. The isthmus typically also measures about 4 to 6 millimeters in the AP measurement, and when the isthmus measures 10 millimeters or greater, then we consider the thyroid to be enlarged, which is thyromegaly. So let's take a little bit closer look at what we're seeing and what we expect to see in the normal thyroid. So the thyroid is uniformly echogenic with medium to high level echoes. So as far as structures go in the neck, the thyroid is actually one of the brighter structures. Here we can see that the thyroid is, again, uniformly echogenic, relatively bright throughout. Typically is going to be more echogenic than the muscles and the vessels that surround it. The thyroid gland should also be homogeneous throughout. So we expect in normal thyroid tissue that we are going to have a soft homogeneous gray displayed throughout the thyroid tissue. We know that the thyroid gland is in the anterior portion of the central neck. A lot of students will try to go very far lateral on the neck when imaging the right lobe or the left lobe, but my advice to you is to start a little bit more centrally and just ever so slightly go to the right of midline or go to the left of midline. You really don't need to go too far lateral to get really nice images of the thyroid. Also make sure that your depth is set appropriately. If your depth is too shallow, then you have potential to cut off some more exophytic nodules that might be hanging off of the thyroid, or you might miss the parathyroid glands, or you might miss some lymph nodes that are sitting a little bit deeper into the neck. So make sure that you have a nice visualization all the way around the thyroid tissue to really evaluate the surrounding tissue along with the thyroid parenchyma. In this example, we can see that the sonographer used dual screen to, again, take a picture of the right lobe of the thyroid, move to the left side, get that picture, and then try to kind of line them up at the isthmus level. As sonographers, we have to be very careful that we don't get too much tunnel vision on the organ that we are looking at. As you can see from this image, there is a lot of relational anatomy sitting around the thyroid. When we are doing a thyroid exam, of course, we are going to focus on the thyroid tissue and get nice images of that, but we also do need to be aware of the anatomy that sits around the thyroid, not only to evaluate it for maybe some incidental findings, but also to be comfortable knowing that these more hypoechoic structures are just muscles, or that the esophagus exists on that medial portion. So knowing your relational anatomy is super, super important. And the left inferior thyroid image is probably the best opportunity for you to practice getting comfortable with that relational anatomy. So let's take a look at some of these structures a little bit more in detail and what they look like with ultrasound. So in this image, we have the left thyroid at the inferior portion. So that is this structure here. This little anechoic part here is a vessel traveling through the thyroid parenchyma. And then I have all of our other structures labeled around it. Notice that because we are coming from the anterior portion, that is the top of our image, and that goes down to the posterior portion. And then normal transducer position has the notch facing medial or towards the patient's right, and then we have the other side as lateral. So let's start with the blood vessels. The common carotid artery, the internal jugular vein, and the vagus nerve are all kind of lateral, maybe slightly posterior to the thyroid. So the IJV and the CCA are going to appear as anechoic structures next to the thyroid. You can put color on them, show that they are blood vessels, and maybe not abnormal lymph nodes. The vagus nerve, which is barely seen in this image here, runs right in between the two. Sometimes in cross-section, that again looks like a little circle here, which might catch your eye. If you were to turn on any of these, they will all elongate into more tubular structures, as that is pretty much what they are. Looking at the muscles, we have the sternocleidomastoid muscle. Again, that is that big muscle that you can feel right on the side of your neck, connects the sternum to the clavicle to the jawbone, supporting and moving the neck. Very, very large muscle. But then we also have these smaller muscles that sit closer to the thyroid, still on the anterior portion of the neck. These three muscles altogether are the strap muscles. They appear a little bit more hypoechoic, but you will see that they have striations through them. The strap muscles again are the sternohyoid. I remember that the hyoid bone is above the thyroid, so the sternohyoid muscle is the highest muscle out of the group. Then it's the sternothyroid muscle. And again, I remember that the thyroid sits in front of the thyroid cartilage, so that's the next one down. And then we have the omohyoid muscle, which kind of sits in between the jugular vein and the sternocleidomastoid. Again, we are going to find value in understanding that these are the strap muscles, because as we are looking through the neck parenchyma, we might see these as abnormal lymph nodes or abnormal structures, and we want to differentiate between normal anatomy and true pathology. Looking more medially to the thyroid, we are going to see the trachea. The trachea, again, is filled with air. It is the tube that goes to the lungs, so we are going to see artifact in there, typically some reverberation from the edge of the trachea, and then kind of dirty shadowing throughout. The esophagus is also the main structure that sits medially to the thyroid, and we see it best on the left. And it's usually going to be a circular structure that sits medial and posterior to the left lobe. There's also another circular structure that sits right next to the left lobe as well. That is the recurrent laryngeal nerve. Again, not a nodule, not something to be concerned about, because we know this is normal anatomy. That is medial. And then lastly, we have the longus colli muscle, or the LCM. We're going to see these on both sides of the neck. They are muscles that sit right on top of the cervical vertebrae. And this is going to typically be a little bit more posterior into the image. Quite often, if we have our depth set appropriately, we're not going to see a lot of it. But if you have a particularly thin person or somebody with very developed longus colli muscles, that might be a little bit more prominent and catch your eye as a possible mass or structure of concern. But again, we're going to check, is it on both sides? Is it near the spine? Is it posterior to the thyroid, deep in the neck? Does it have the striations? It's most likely the longus colli.